All right, hey everybody, and welcome to today's Oncology Data Advisor interview. Today we have a really exciting conversation planned. So we're currently wrapping up an amazing 2 years with Dr. Rahul Banerjee as editor-in-chief of Onc Data. We've seen some really great growth over the last couple of years and covered some really important topics. We're super thankful to him for his service at the helm of Onc Data these last couple of years. And we're also welcoming our new editor-in-chief, Dr. Matthew Hadfield, who has been on our editorial board for a couple of years now and has been a fantastic contributor. And we're really excited to see all the great ideas that he has for Onc Data, over the coming years. So with that, I will turn it over to Dr. Banerjee to start off this conversation about where the field is right now, some of the challenges that we cover, some of the new innovations that we're looking forward to, and looking forward to hearing from you.
Perfect. Thank you, Kira, for
Thank
all of
you.
your help behind the scenes with the last 2 years with me at the helm. Excited to pass the baton on to Dr. Matthew Hadfield here, who's an assistant professor of medicine at Brown University at the Legaretta Cancer Center in Providence, Rhode Island. Dr. Hadfield, Matt, if I may, congratulations, and I'm looking
Thank you.
forward to having you take the helm.
Very, very big shoes to fill, to be honest.
Yeah, it's
But
I mean, this has been a lot of fun. Yeah, because I think as some of you may know who are listening, I've the website has grown a lot and a lot of content that we've covered. I think what I've really enjoyed as editor-in-chief is writing those columns every 3 or 4 months. And more recently, it's been about, what can the oncology field learn from XYZ? And I think one of my favorite ones was writing about, Jimmy Carter. And you may remember how he ended up passing away last year, but after being on hospice for years, way longer than anyone
Mhm.
expected. And I would argue that, you know, he lived longer on hospice than he would have on treatment. And I feel like we don't really talk about that. It's a nice question to stump medical students on that you don't need to only live 6 months to be in hospice. You need a 6 month life expectancy, but knowing that he lived a high
Right.
quality life there, just like you can't really write about that kind of stuff in any other forum. And I think Oncology Data Advisor is nice to just talk about these bigger picture themes.
No,
Um,
absolutely.
but that was so last year, passe at this point. So much has changed in the world. I mean, I guess looking forward to your term beginning in 2025, early 2026. What do you see as some of the big issues in oncology or cancer care?
I think some of the things that I think are still big issues that are maybe a little disappointing is the fact that there's still data to suggest that we're not doing enough targeted sequencing of patients' tumors outside of large academic medical centers. I think I've seen a lot of initiatives about globalizing
Mhm.
NGS testing, but to be honest, I think we still have a lot of work to do in our country. I think you know we have to be really really careful, and I'm sure you probably see this in myeloma. We were joking before about how I see melanoma, you see myeloma. There's lots of overlap, just a name,
Uh,
but
Agree.
uh, the the lack of the uptake of comprehensive genomic testing, I think, is a big thing. And the other thing I think is as these therapies get more and more complicating and promising, kind of drawing from both of our worlds, like something like teclistamab, while it's a great drug in myeloma, there's logistics in giving it, right? You need to have ramp up dosing, you have to have inpatient admissions, there needs to be familiarity with CRS monitoring. I mean, great things, but just lots of logistical burden to trying to bring these therapies to a broader population. And I think the field is moving so fast that we have to scale it as opposed to just develop things. So I don't know if you have any thoughts about
Uh,
what you
I
think.
Completely agreed. Yeah, I know it's interesting because I feel like I learned a lot more about melanoma recently with lifileucel being approved and these pills, tumor infiltrating lymphocytes. And I attend on our CAR T service at our institution at Fred Hutch in Seattle, and I learned a lot from them. And I think the patients intrinsically are clearly aware that I am not a melanoma specialist. They don't even try to ask me to pronounce the names of the drugs they're on because I would not be able to. I can go talk to myeloma and lifileucel, but they lean to us to talk about CAR T therapy and the toxicities that extrapolate to TIL therapy, and that's it's hard. And it's hard because even at a specialized center like this, things are so uber specialized. We can't get our worlds to near collide maybe as nicely as we would like. We're still figuring out, obviously, and I think it's a relatively smooth experience, but work could be done. And NGS is a good example, yeah, where I think the melanoma doctors thankfully know what to do with it. I don't even know how to send that. And so they work very closely with us, but as you're alluding to, I think for probably half the US, if not more, they do not live within 30 minutes of a center like this that can do these cellular therapies or this even basic, next generation or comprehensive genomic sequencing to figure out what to do next. And so it's a challenge. Obviously, across the world is even bigger challenge, but even within the US, it's tricky. And I think a lot of the times, you know, community oncologists don't have the resources to it, or patients don't realize they should be asking for it, or even if you want to get it done, there's the hurdles to going to a third party vendor, getting up the linkages set are tricky. For us in myeloma, not melanoma, we don't use NGS as more. We don't use genomic sequencing as much per se to look for new qualitative mutations. We have a next generation sequencing platform to look for MRD, measurable residual disease. And the same thing applies where, for example, in myeloma, the New York Times wrote this article this year from, from like hopeless to potential cure in multiple myeloma, talking about how MRD decision making is changing the world. We can't even get
Right.
half the country to check for MRD because it's not the doctor's fault, right? It's just so impractical at these smaller centers, requires a bone marrow biopsy, first pull being sent to the lab, a lot of resources, which is tough.
Yeah, and I'm so glad that you mentioned MRD testing because, to be honest, I see these overlaps in the fields where what's important in one field is kind of switching to another, and then vice versa.
Mm-hmm.
So MRD testing is something that I think has been more relevant in myeloma, but now we're starting to see it more in the solid tumor space, and we're trying to figure out what to do with it in like the adjuvant and the neoadjuvant settings, and then even disease monitoring and things. But then you take things like immune checkpoint inhibitors are now being used in like lymphoma, and it's like we're the toxicities are new for people, so
And
things are changing fast. But for some people, what's old is new, and it's a whole new
uh,
landscape.
agreed. No, I mean, it's fast. I mean, that's the power of oncologists working together and the power of talking to people across disease group lines at academic centers. I will say for us, immune effector cell associated enterocolitis is this, now it's a box warning on cilta-cel, which is our biggest, most commonly used CAR T therapy for myeloma. And it's basically patients get horrible bloody diarrhea, not infectious. We don't know what's going on. And we, in our malignant heme world, tend to say, oh, well, everything in life is either caused by too little steroids or too much steroids. And we just give steroids. And actually, it's not the optimal treatment for this. The optimal treatment for polyclonal T cell infiltration, CAR driven into the lamina propria of the gut is actually to use what the solid tumor world has taught us for melanoma, where you have checkpoint inhibitor colitis, you use like, vedolizumab or
And
infliximab or
yeah,
these
yeah.
biologics. And so we've started using that, and it has been my first time prescribing infliximab, I think, ever. I didn't have to use it as a fellow, and it's cool. And thank goodness for people both within the oncology field and outside of it, like our GI colleagues who cover both worlds, both solid onc and now ours, are like, oh, well, your colleagues on that side of the office are using infliximab for, melanoma or for lung cancer for checkpoint issues. Why don't you? I'm like, oh, I learned something. So it's the power of Oncology
No.
Data Advisor. We all learn from each other.
Well, that's actually that's a good plug, because I was just saying, thinking to myself that like those are the things that I feel like a platform like this is so good at is I mean, at the end of the day, we obviously rely a lot on literature. We rely a lot on going to big meetings and things, but it's so specialized. And to be honest, we're inundated with so much information all the time from so many different sources that sometimes a more of a social platform like this is where you can learn the most because it's anecdotal and it's not dense. I mean, it really is like. We've been having conversations about that here because things like vedolizumab or infliximab or mycophenolate, these drugs that we use in melanoma for toxicities, they have lots of their own side effects that can sometimes be
Agreed.
confused with the checkpoint inhibitor side effects.
Agreed.
There's lots of overlap, so it's getting very very complicating very very fast. And then I think getting back to that point for like, are we going to be able to scale this out to everyone? Is it really going to be something that is the directions that we're going? We have to be mindful of how to make it accessible to everybody because it's going to be harder and harder.
Agreed. I mean, we were talking about this before we started the podcast, right? One of the issues right now, we're filming this on November 10th, 2025. There is no telehealth waiver, has not been extended for Medicare recipients. And so it's been challenging because a lot of our patients, like that is their window to benefit from the partnership between the community oncologist who knows them the best and the academic oncologist who knows the disease the best. And so honestly, like a third of my patients here in Washington State whom I see in clinic are actually from Idaho, Montana, Alaska, etc. And it's been devastating for them because basically they're being asked to make an impossible choice. Like either you don't see the academic specialist or you drive or fly to see them, which makes no sense at all. And it's interesting because that's one of the things that we were just talking about this. Like I'm seeing it within my myeloma space, but that's the kind of health policy issue in the US that's cutting across, your clinic and melanoma, crossing across everyone's clinic, needs to get fixed. But many things need to get fixed, but that, for example, is one of them.
I mean, just to ask a little bit more about that, I mean,
Yeah.
the Medicare waiver going away for the telehealth visits, like, what do you think the long-term implications of that are going to be if there is no change? Do you think people are going to no longer be able to access academic medical centers? And I mean, to what degree is it going to cut off that access? Because to me, I mean, yeah, to your point, like you're just forcing people to drive, to fly, to try and make it, and then you're putting up these barriers that don't need to exist.
Absolutely so. And I think for me, the patients I worry the most about are the ones just getting them in the door to consider an academic consultation or, a CAR T or lifileucel referral, for example, is the hardest part, right? Because I think unfortunately we sometimes feel like the ivory tower, hard to get here for a lot of our patients, right? Be it in Providence or Seattle, just like being on a busy highway is like new for them, terrifying for them. Everything is scary about the big city. And so it's hard. And I think telehealth is a really nice way to at least show that I don't bite. I'm not there to take their money. I'm here to help and I'm here to work with
Right.
their primary oncologist. And I think telehealth has helped extraordinarily there. We've dealt with challenges before, like when at least, in Rhode Island, it's funny because I trained there for undergrad med school. Rhode Island is smaller than some of the other states, but the same issue applies with patients coming across state lines for care. That became
100%.
challenging with the COVID waiver going away, but we were able to figure that out. In my case, I have an Idaho, Montana, and Alaska, California, Washington state license, so I can at least ethically, and legally see these patients and offer medical advice no matter where they're sitting. But I think now that I can't even see them, period, I think it's tricky. I think a lot of them, the ones who were known to us, I think they've gotten better at being able to send us electronic, messages through the electronic medical records, or at least they have some way of getting in touch. We have a phone number. It's the ones who could benefit from a one-time consultation with us, who no longer feel like it's practical. They're the ones who will fall through the cracks, and they won't see us um, until it's too late, until they've gotten therapy that unfortunately was suboptimal, to your point, because they didn't have someone telling them about doing genomic sequencing, or in my case, they didn't have someone say, look, you should go for CAR T therapy while you can, because it's better than your standard treatment options. Those are the ones I worry about. And even if it gets fixed in the next month or two, I do feel like, as you know, loss to follow-up is a big problem in oncology, particularly for vulnerable patients, rural patients, patients with limited access to healthcare. And I feel like even some of those patients, even 3 months without, when their scheduled visit with us got canceled because it's a health issue, they may not schedule again, and we may lose them logistically until things are too late.
Right. No, and that's your biggest nightmare right there, is that, you're losing patients, and they're not making it back to you, or they're not getting the care that they need in follow up, especially as you think about these therapies like CAR T, where it's not like a one and done thing. There's ongoing, potential for toxicity and harm. So very, very big issues, and important ones. So I guess to round out, what would you say
Yeah.
has been one of your best experiences over the last 2 years with Onc Data Advisors, and what advice do you have for for myself, the incoming chief?
Absolutely. You won't need my advice. You will do amazingly. But I think, yeah, I think writing those, making those comments, those columns big for me, I feel like was really illuminating for me myself to kind of talk about these bigger issues like hospice referral, telehealth waivers, like things like that, I think are really important. And I think leaning in on the community of oncologists who are here, as you know, and I know well, both of us actually joined this website when we were fellows. And I think Oncology Data Advisor in particular is like very uh, uh, friendly towards fellows, junior faculty, et cetera. And I
Hmm.
think leaning on them because they have the best ideas, right? You and I both joked about how, neither of us are AI experts, but we will someday before to become AI experts, but we have other people on our board, for example, who specialize in this, right? And he's wonderful. And you learn from him, right? I think a lot of
Right.
the more junior faculty and fellows, they're the ones thinking of these most innovative ideas, cross-cutting across additional disease groups in terms of access to care, health policy, AI, all of that, which is really cool. I mean,
Yeah.
anything on your bucket list for the next 2 years that you're excited to work on or write about or talk about?
Yeah, no, I think that for me, kind of in the same vein of what you were talking about with things like referral to hospice, there's a lot of things that I feel like are very if you've been in medicine, you've been in oncology for long enough, you kind of know and you understand how things work, but it seems slightly inaccessible as a trainee because you just don't know the questions to ask. So
Hmm.
I would say, on that thought, things like clinical trial design, like just basic information on how to understand hazard ratios and things. I mean, there's so much
Oh,
about
really
oncology
good
that's just
point. Very good
different
point.
than other fields, you know what I mean? And trying to break that down for trainees so it feels less intimidating. It's okay to ask about, like, how was the study designed? I mean, because inevitably you read a paper and then you watch a podcast. They're like, well, the alpha allocation was this, and you're like, I don't even know what alpha allocation means, but I'm too afraid to ask. And
Completely agreed.
yeah, so topics like that, I think I'm most excited about to try and break down and make a little bit more digestible for fellows and trainees.
Excellent. Looking forward to it. Well, with that in
Yeah,
mind, yeah, I mean, I don't know exactly when the baton is being passed from one coast to the other, from sea to shining she of the US, but looking forward to it. And for all of you listening, thank you again for your time and continued support of our platform.
yeah, thank you so much.
Absolutely. Awesome. Well, I love all these topics that you both brought up today. And I agree these are the pressing issues that are so important for Onc Data to cover and encourage these conversations within the community. So we're so excited to keep working with both of you to have these conversations and hopefully foster this change. So with that, thank you again and looking forward to next time.
Thanks, Kira.
Great. Thank you again, Kira.